The grid up there that Pierre came up with all the variations that are possible. And essentially there's three areas where variations can occur. We can get variations around the ophthalmic artery, and we've looked at most of those. We can get variations around midline fusion of the anterior cerebral artery, and then variations related to cortical and perforator balance at the middle cerebral artery. I'm not going to spend time on this because this is the classification that everybody gets taught at medical school for cerebral vessels. And although everybody uses it, you'll see it's not as useful as understanding the variations. So that's why we're going to look at it a little differently. So Carl has told you that during embryogenesis, at the time that we've got the brain vesicles, the thing that's driving the development of cerebral vessels is the choroid plexus. The anterior cerebral artery is a choroid plexus artery initially, so we've got at the level of the diencephalon, the anterior choroidal and the anterior cerebral coming around to meet at this point. So that's what's driving the development of the vessels. Thereafter, as the brain starts to develop, the vessels are developing in a secondary way, and that's why the middle cerebral artery ends up being so big, and the anterior cerebral develops big cortical territory, because the brain develops and it needs more blood supply. So we said there's these variations around here, and we've looked at them. There's the infraoptic A1, a duplicated A1, and the anterior cerebral origin of the ophthalmic, and the true ventral ophthalmic persistence. We're not going to look at those. So let's go straight to the anterior cerebral artery, the midline fusion issues. And here, there's four things we want to look at. The completely fused anterior cerebral artery, the azygos, the completely unfused, the unpaired anterior cerebral artery, the bihemispheric supply, and the triplicated supply. So this is the terminology that's used, right? So this is, we either call it a completely fused or unpaired artery, or complete unpaired artery. This would be the azygos artery. And although it's common, it's not common. It's uncommon in animals. It's almost I've never seen a completely fused anterior cerebral artery. It's usually a part of it that's fused. So something like this, an incomplete, unpaired, or partially fused anterior cerebral artery. And I think everybody's seen examples of this. And because it's not a fully developed system, it's often associated with aneurysms. And you can see an aneurysm here, right at the level where the fusion stops. And then we have this bihemispheric supply, where we can have dominance on one side. So we have one artery that supplies a large part of the corpus callosum and a part of the hemisphere, and because it's in balance with the other side, the artery on the other side is smaller and may just supply some of the cortex. So this, again, really common finding in angiography. You'll do a right-sided injection, and there's a tiny A1 with hardly any cortical territory. You do a left-sided injection, and there's this bihemispheric supply. You see supply to both hemispheres. And often the A1 size will reflect that, right? So on the side of the smaller cortical supply, there will be a much smaller A1. So we have an unbalanced A1 supply to the anterior cerebral arteries. And then we have this possibility of a triplicated vessel, where we have a midline vessel and then two vessels on each side of it. Again, this is not such a common finding, but if you do 3D angiography, you can see here we've got a big central vessel that's supplying both hemispheres, as well as a smaller vessel on each side with a cortical territory. And then we've spoken about the possibilities for supply to the corpus callosum, and these are the three possibilities possibilities. The subcallosal artery, this one here, that's going to supply mostly the anterior third ventricle, the anterior commissure, with a little bit of supply at the bottom of the corpus callosum. We can have a median callosal artery, where the artery originating off the triplicated ACOM is much larger and is going to supply the corpus callosum almost entirely. And then we have the more conventional supply of the pericallosal artery, where the artery that runs over the corpus callosum is giving off supply into the corpus callosum, as well as cortical hemisphere supply. So what about the middle cerebral artery variations? So the first thing is we have different perforated territories that we need to talk about. And let's start with the development of the striate perforators. So this is what the striate perforator supply looks like in the amphibian. So we have carotid artery, caudal division, cranial division comes up, continues in the anterior cerebral artery, which gives off these little branches that are supplying the basal ganglia. As part of that, off those striate branches, we have a cortical supply, so a little bit of cortex that's present in the amphibian, and that's the branches of the middle cerebral artery. In primates, though, we get a separation of the supply. It's like we're taking scissors and cut it down here. So we now have perforators, striate supply that's going to come off the anterior cerebral. So these are the medial striate vessels based mostly around the Huebner vessel, that can be separate. And we have lateral striate arteries that are going to come off the middle cerebral artery. The middle cerebral artery, as you know, is really develops from the striate vessels. They're there long before the middle cerebral is there. In primates, the middle cerebral artery just becomes a much larger vessel because it has a big cortical area that it needs to supply. So I said there's other perforated territories, and let's just look at those first. So we've got deep perforators, the diencephalic perforators that are related, of course, to the proximal anterior cerebral artery, this cranial division of the internal carotid. And these would be optic chiasm and hypothalamic perforators. So off the supply to the optic, again, an operative view, here's the right optic, left optic, chiasm, and you can see these tiny little perforators that are often coming from the anterior cerebral, running over the chiasm. They're very well collateralized, and they supply the undersurface and the top surface of the chiasm. Then we have hypothalamic supply that's going to be coming off the posterior margin of the A1, A2 junction. That's what puts at risk when we're clipping ACOM aneurysms. So here's right optic, left optic, clip going across this aneurysm. And the difficulty here is if you can't see behind the A2 vessels, those are the perforators that are at risk of being damaged because you can't see them. So this would be the typical example. This is the chiasm over here. Here's the A2 vessel. There's the aneurysm that's going to be clipped. This is a fenestrated clip that's going to be applied blindly, hopefully just over the neck of the aneurysm, but it's very difficult to see the little perforators at the A1, A2 junction. So you certainly may be able to see them on this side, the right side, but on the left side, almost impossible to see them. And that's why patients with clipping of ACOM artery aneurysms have a high risk of hypothalamic injury. So those are the deep diencephalic perforators, and we spoke a little bit about the striate perforators, so let's look at them in more detail, the medial and lateral striate vessels. So these are the telencephalic perforators as opposed to the diencephalic perforators. And there's different patterns. So although we talk about medial striate vessels and lateral striate vessels, there's a balance between them. Here's an example of a patient with a strong medial supply that's covering the lateral territory as well. So you can see here, carotid artery, middle cerebral, A1, very large Huebner artery, and this Huebner artery is carrying all the striate vessels, medial and lateral. There's almost no perforators coming off the M1 segment. This would be the distribution that's more likely that we see in textbooks, right? So we've got medial striates coming off the A1, lateral striates coming off the M1. And then we can have a very lateral dominance. So this is an example of the patient, almost nothing off the A1. But when we come to the M1, and you see I'm including M1 right up to the turn of the insula, so the fact that the vessels bifurcated doesn't mean that this isn't part of M1, and that's why these are striate perforators, medial and lateral, that are coming off the M1 that's supplying the entire territory. So I've shown you three possibilities with just a shift in the balance of the perforator supply. So when the question was asked, is it safe to close the A1? It may be, but it may not be. And it depends on looking at this balance of perforator supply. So there's all these possibilities on the grid, and you can draw them out. We can have a candelabra supply where we have one large vessel that's supplying a lot of the perforators. We can have individual supply. We can have Huebner taking over things, and we can even have a little perforator to perforator anastomosis that forms a bridge. And that would be how we end up with variations that look like this, right? So we've got, if you look at the publications, this would be called a duplicated M1. It's not. It's just persistence of perforator to perforator anastomosis, but because of flow, is becoming enlarged. So let's look at this one. Here we have carotid artery, middle cerebral, anterior cerebral, and there's this vessel coming off here. So it's not in the typical position of the Huebner vessel. It's coming off from the middle of the A1, and it's presumably a striate vessel. You can see the striate vessels coming off there. Why am I showing you that? I'm showing you that because when we get to the accessory middle cerebral artery, there's all these variations that are possible in the origin of the Huebner vessel. So this is what we call an accessory middle cerebral artery. So we've got carotid, middle cerebral artery, A1, Huebner, but the Huebner is taking on all the perforators as well as a cortical supply. Here we go. So this is an example. We go carotid, here's the middle cerebral artery, A1, and then coming off the A1 in that position that I showed you in the last case, we've got the Huebner vessel, all the perforators, the telencephalic, the striate perforators coming off this vessel with the distal cortical territory. So this is an example of an accessory middle cerebral artery, which is really an enlarged Huebner with a much bigger cortical territory. Another example, but now we've got the origin off the A1, A2 junction, right? So this is looking from the top. Here's the Aca complex, the anterior cerebral arteries. Here's the left middle cerebral, and then coming off from the region over here, we've got the Huebner with a big cortical territory, an accessory middle cerebral artery. It can be really small. So here's a carotid, A1, again that example of a medial striate vessel, a candelabra type Huebner that's taken over all the perforator supply, but has a small distal cortical territory. Here it is over here. So it's not insignificant, it's a cortical territory, and it can be small, like this one. And we go to the other extreme where it can be absolutely massive. And the accessory middle cerebral artery can be larger than the real middle cerebral artery. So here we go, carotid, middle cerebral, A1, very large accessory middle cerebral artery, all the perforators coming off this vessel. Nothing off this one. They can be associated with aneurysms. So accessory middle cerebral artery, so here's the real middle cerebral, accessory middle cerebral, aneurysm in between, after the aneurysm is treated. And I'm showing you this because, of course, when patients develop delayed ischemia and spasm, it's much easier to see the perforators. And here's the striate perforators, very clearly seen, all coming off this accessory middle cerebral artery. Another example, really small MCA, big accessory aneurysm. This, of course, is not an example of an accessory middle cerebral artery. So we can have very proximal temporal branches. The difference here is this branch is coming off the MCA, not off the carotid. So this is a proximal temporal branch. Same as this one, proximal temporal branch. A little bit about cortical territories, so they are highly variable. So you can see we can have accessory vessels, we can have early bifurcation, we can have almost no bifurcation, trifurcation, all these variations are possible. No bifurcation or separation of the vessels at all. How do we make sense of this? The easiest way is to define the anatomy based on the cortical gyral pattern, which is a lot more constant than the vessel pattern. And that's why we break up things into, it's easy to draw this out, even on an angiogram picture. You can put the corpus callosum, the singular gyrus, a sulcus, and then on top of that build up a pattern of vessels. So what we've done here is just color the corpus callosum supply in red, and then we name the rest of the vessels related to the cortex structure. So this is the orbitofrontal, frontopolar, anterior frontal, middle frontal, parietal frontal, this is the, posterior frontal. Then we've got the precentral lobule, superior parietal, and inferior parietal branches of the anterior cerebral artery. Same thing we can do with the middle cerebral artery. We can draw out the structure of the underlying brain based on the curves of the vessels. So you'll know that where the vessels are exiting the Sylvian fissure, we can draw a line. And that's where all the vessels are taking this turn out of the Sylvian fissure. So these loops here are the vessels exiting the Sylvian fissure. You can draw a straight line there. Underneath that, it's possible to draw the insula. And then we can draw out the sulcal structure. You can imagine it, right? So this is superior temporal gyrus. Then we're going to put in central sulcus over here, and the inferior frontal gyrus. We can just draw them out. If you draw those out in your head, then you can start naming the vessels. So we start with the upper division. These are the vessels that are going to be going superiorly out of the Sylvian fissure. And that would be orbitofrontal, frontopolar, precentral, central, the anterior parietal, posterior parietal, angular branch. And if you do stroke work, all of these vessels become quite familiar, right? Because there is a little bit of a pattern. And then we get to the inferior division branches. These are the branches that are going to be going inferior over the temporal lobe out of the Sylvian fissure. So temporal occipital, posterior temporal, middle temporal, anterior temporal, and temporopolar branches. Why is that useful? And sometimes we have to get into those distal vessels if we're treating AVM, or in this case, infective mycotic aneurysms. So the patient's got two aneurysms that don't know which one is bled, so we need to treat both. You can see I've just sketched out the sulcal pattern on this. Makes it easier to get to. This one I know is in the angular branch. The angular branch is going to be the straight one. I can find it proximally with a microcatheter, not waste any time, and we can treat those aneurysms. Finally, you know that there's balance between all of these vessels as well, these cortical territories. This is particularly so if you do stroke, you'll notice that, of course, we're looking for shift in cortical territories. And there can be just normal shifts. You can have posterior cerebral supply that's larger than temporal supply of the middle cerebral. There's just a shift in watershed that's normal. But of course it becomes apparent when we do stroke and there's one vessel closed, and then you can see if there's peel anastomoses that contribute to the territory that's closed. And then there's variations that are not described on an embryological basis. Some of them we've been over, like this early bifurcation of the middle cerebral artery, which really has no clinical meaning. It has some anatomical meaning if you're going to surgically operate, and you need to know which operative approach to use to reach an aneurysm, because the vessel is deep or proximal in the Sylvian fissure. And then we have these that I can't explain on an embryological basis, these dolichoectasia dilated vessels that may be acquired rather than congenital. But there's certainly some patterns that are probably occurring very early during embryogenesis. So this looks like an absence of the proximal M1 with collateral flow through perforator to perforator anastomosis that's enlarged because the proximal M1 has disappeared during embryogenesis. So we've got a middle cerebral artery that looks ectatic, but is probably just a reconstituted perforator to perforator anastomosis. Thank you. Sorry if I went a bit fast, I'm just trying to save some time. So any questions?
Questions?